Hi, my name is Dr. Michael Schilsky. I'm professor of medicine at Yale University Medical Center, and I'm here today to talk to you about monitoring of Wilson disease therapy. Monitoring is a process to periodically collect, analyze, and use information to actively manage a disease to maximize the chances for a positive patient outcome while minimizing the risk of adverse events. Common baseline elements should be collected before treatment is initiated, and monitoring must be conducted at regular intervals going forward for the life of the patient. Monitoring frequency and testing can be individualized for each patient, and this may take into account specific treatments. However, core elements should be attained on a regular basis. Three key tenets for monitoring to keep in mind include monitoring for effectiveness, safety, and adherence. I will next discuss the following: what information we should collect, how often should we collect the information, and when to change the frequency and type of monitoring. Monitoring frequency is phase of disease dependent and also circumstance dependent. Initial therapy, when therapy is first begun for Wilson disease, is the time typically when we do more frequent monitoring, and it may depend if the individual is asymptomatic, in which case we should look typically about 4 times a year, or if they're more frequent if the patient has particular symptoms. Maintenance therapy maintenance monitoring is the monitoring of what we call maintenance therapy, and that's the lifelong monitoring that occurs after that initial period is completed. And this includes regular interval monitoring, typically at 6-month basis. And there are special circumstances when we need to step up and more frequently monitor, and this includes when we suspect there is a treatment failure, if patients become pregnant, if they have change in their symptoms, whether it's neurologic, psychiatric, or related to their liver disease. In particular, we worry if there is liver failure, or when therapy is changed. Baseline testing should occur before treatment's initiated, and this includes a careful physical examination. And if the patient has neurologic issues or mental health issues, that may also include very detailed evaluation from neurologists or mental health professionals, in addition to specialists for liver disease. And also, an ophthalmologic exam may be performed for Kaiser-Fleischer rings. Typically, once a patient is above the age of 5, that should be considered. And in children, separate from the Wilson disease part, we also need to consider standard evaluations of growth and development, which are typically conducted by our pediatric specialists. Other testing is laboratory testing, liver imaging, liver biopsy if it's needed for diagnosis or disease, and that includes histology and quantitation of the copper in the specimen, as well as brain imaging and MRI or CAT scan if there are neurologic or psychiatric symptoms present at the outset. Laboratory testing includes looking at blood counts and platelet counts, prothrombin time, and what's known as a normalized prothrombin time, or INR, liver tests, and tests of electrolytes and kidney function, and other blood tests may be serum copper and ceruloplasmin, uric acid, and if cirrhosis is present, an alpha-fetoprotein, which is a liver tumor marker. Other things that can be measured include iron parameters, iron binding capacity, and ferritin to have good baseline values, as well as urine analysis and a 24-hour urine for copper and volume prior to treatment initiation. Imaging should include at least an ultrasound or maybe a CAT scan or MRI just to know structurally how the liver is doing, and if it's available, elastography, which helps us look non-invasively at the scarring in the liver. Additional baseline testing may include mutation analysis for ATP7B, and this is useful for family screening. And bone density testing can be performed to have baseline in adults, and this helps us later on, especially when we are concerned about potential loss of bone density at a faster rate in some patients. There may be urine, for those on zinc therapy, urine and serum zinc levels may be helpful to then know later on if the zinc is being absorbed well. And there should be testing for immunity to hepatitis A and B and immunization if an individual has either not been exposed or not received immunization before to protect against these disorders. Follow-up lab testing that should be performed at intervals includes blood and urine testing, and this includes blood counts with platelets, prothrombin time and the normalized prothrombin time, INR, liver panels and basic metabolic profiles, urine analysis for patients on chelation therapy, and 24-hour urine copper. And for those on zinc therapy, you can measure it in the same specimen, zinc, and that just would be reassuring for the absorption of the zinc as well. Other optional measurements include serum copper and ceruloplasmin, and elastography in patients who've had it before to see that it is not changing, especially if the patient does not have advanced fibrosis or cirrhosis. If they have cirrhosis present, then separate liver imaging should be performed for liver cancer, typically twice a year, and they may need screening or surveillance for varices, which are the blood vessels that become dilated in either the esophagus or stomach and increase the risk of bleeding complications. And this can be done either annually or if a patient is placed on beta blocker to prevent bleeding, may not need to be done at any frequent interval. Now, initial therapy is the time when we look most closely. As I mentioned, there's the core testing that needs to be done, the pre-testing, and then the core testing that can be done afterwards. Typically should be done about 4 times during the first year, and then more frequent if testing is abnormal or if there are symptoms which are changing. Importantly, for those with neurologic disease who start chelation therapy, you have to pay attention to the clinical exam and symptoms, especially during that first to 6-12 months of therapy, when they may be at risk for what we call paradoxical neurologic worsening, that is, worsening of their neurologic symptoms despite being treated specifically for their Wilson disease. And 24-hour urines for copper and zinc should be performed 2 to 4 times during this initial period, more frequently if it is needed to help direct therapy. Monitoring for maintenance therapy should be performed twice a year at minimum, and this helps us detect problems before they become clinically relevant. 24-hour urines for copper and zinc should be, again, typically once a year, twice if there are any issues. Elastography can be performed if it's available, probably no more frequently than annually. We should change our frequency of monitoring, in other words, step it up, if patients have abnormal test results, especially if there is a trend towards worsening, if they fail to reach treatment targets, and this may be normalization of liver tests for some individuals or urine coppers that are outside the ranges that are determined for their particular therapy. If there's an appearance of new symptoms or reappearance of symptoms that once were present and improved with therapy, this may be a sign we have to step things up and look more closely. For pregnant patients, we do recommend getting testing each trimester with liver tests. That you typically get blood counts for other reasons, and the liver test can be added on to that. And this is especially true because many patients on chelation therapy are recommended to lower their dose during the pregnancy. They need to maintain treatment, but if they're going to a lower dose, which may increase safety for the developing fetus, then we want to know that it's still effective for them. If there is knowledge that the patient has been non-adherent, that may come from the patient themselves, may come from other caregivers around them, or even a pharmacy that may let the provider know that the patient has not been picking up their prescribed therapy in a timely fashion, then we may need to, again, step it up and work with that individual and try to find a way to improve adherence. If patients change therapy from chelators to zinc or zinc to chelators, then we would want to repeat the standard testing. For those going from zinc to chelator, we should now be doing urine analysis along with the core testing, and we want to do this somewhere between 4 to 12 weeks after the change in therapy. For these individuals, urine copper excretion will increase. If they go from chelator therapy to zinc therapy, we want to repeat again the testing in that 4 to 12 week period. In this case, the urine copper excretion is going to decrease typically to under 100 micrograms a day over time. And if there is worsening, obviously, in the individual, and that's the reason for their change in therapy, then you want to do these testings earlier as opposed to later during that interval. Now, clinical monitoring is important. That is examination, as well as speaking to the patient about their history of their symptoms. And also, if they have cirrhosis, we want to monitor for hepatic encephalopathy, manage fluid accumulation. And neurologic disease, we want to follow patients, especially if they have dystonia and tremors that may interfere with their activities of daily living. Similarly, or if they have speech and swallowing issues, this may pose safety problems or communication issues, and these need to be monitored and worked upon, perhaps separately with other specialists. And similarly, for mental health, if a patient has a mood disorder or experiences impulsivity, or especially if they have suicidality, this requires additional professional help. Adherence is important for achieving an excellent outcome, and we again use the history that we get from patients to help us or from those around them. Liver tests tend to detect this early, which is why we do this on a more frequent basis. And similarly, 24-hour urines for copper will change from what their baseline values are, either become higher for some patients that had previously been good with therapy, and then in patients on zinc, it may actually be lower. Zinc values in the urine may tip you off that they're not taking the zinc or not taking it properly, may not being absorbed well. And you can also perform a slit lamp for Kaiser-Fleischer rings. Again, if they were absent before and they become present, that's a hint of either non-adherence or treatment failure. And we usually can use serum copper and ceruloplasmin as well. We hope a better assay for non-ceruloplasmin copper in the future will help us detect, again, changes in this copper bioavailability before it becomes a problem to the liver or other organs as well. Now, one thing that can occur, and it doesn't happen early in disease, usually very late, is overtreatment. And in this case, we might find the urine coppers become very low, below our targets. Serum copper becomes low, and similarly ceruloplasmin, which is often low in patients to begin with, can become even lower. Iron values, because we need the copper to help move iron around in cells, actually become elevated in tissue. So we might see an increase in iron binding capacity or ferritin values suggesting increased iron storage. We also might see changes in our blood counts, and that is the white blood cell count, in particular the neutrophils, may be low. Similarly, the platelets may be affected and decrease as well. From a neurologic standpoint, new appearance of neurologic symptoms in a patient who's very well treated should prompt some thought about overtreatment too. Patients can develop neuropathy, posterior column symptoms where they may have changes in either proprioception or balance, and this can be confirmed by MRIs of the spine where you might see demyelination, and certainly an important for these individuals have a careful neurologic exam and attribute it to overtreatment and not undertreatment, which might actually step up therapy and push it in the wrong direction. Now, what's new includes a method to detect the bioavailable copper, and that is using column chromatography to separate the proteins in our serum, in our circulation, and then using mass spectroscopy to help identify the copper quantitation in these separated proteins. Shown on the top is an example of ceruloplasmin peak in a patient with Wilson disease. You'll note that it's low. And similarly on the bottom, in a non-affected individual, you'll see a higher peak value. And when you measure the copper in this peak, it's exclusive to ceruloplasmin. This methodology allows for very high accuracy recovery and is highly reproducible. And it has actually been used, if you subtract this total copper in the ceruloplasmin peak from the total, to determine that bioavailable copper or the non-ceruloplasmin copper. It was used as a primary endpoint in a clinical study comparing D-penicillamine and trientine, and is now being looked at experimentally in separate studies to determine if it is useful outside just the group that has stable disease, so that we can see if we can detect changes in this in patients which may have either treatment failure or during the initial phase when we expect the values to be higher. Ranges for this in various conditions needs to be established, and we hope over time this will become a new standard and help us with monitoring for disease. So in conclusion, monitoring is essential to maximize the chance for best patient outcome. We can detect treatment failure and non-adherence earlier before it becomes a serious problem. And we can look and detect side effects of treatment, including the paradoxical worsening neurologically, or later on signs of overtreatment. We hope that improvement using the non-ceruloplasmin copper methodology by speciation will improve our monitoring and simplify the process, give us useful targets for treatment associated with good clinical outcome, and really help us individualize treatment dosing as well as detect overtreatment well before we currently can. This is the guidance document that has been published by the American Association for Study of Liver Disease. Many of you will recognize a number of the very engaged people in the Wilson disease community, physicians with great expertise that were pulled together to help put this document forward. It is a great source of information, mostly meant for physicians, and it has detailed information on each of the medication, has a table with treatment targets, helps define treatment failure in special circumstances for changing therapy, and discusses monitoring and adherence. I suggest for many who have any difficulties bringing this to the attention of your physicians that are working with you if they haven't already seen it. And for those who wish to become very educated, it's a great place for information, but it is sometimes challenging. And so then please ask your physician and try to learn more about some of the information there. But it is a great resource. And finally, I'd like to thank everybody for their attention and share with you a photograph of a patient who has kindly agreed to share this picture with you all today. She is 93 years old and has achieved this 93 years with her Wilson disease because of the monitoring and care that she's received over the years. And she wanted to share this with you all today so that you know, one, you can achieve this and you can live with your Wilson disease, but take your medications and work with your physicians for the monitoring to get your best outcomes. Thank you, and I look forward to your questions. Thank you to the Wilson Disease Association for providing us the opportunity to be here with you today. This is a special year for the organization, and for those of you who are just joining us newly, you'll begin to understand how important this organization is in providing educational opportunities, as well as what Dr. Ascari mentioned in terms of both their longstanding history of helping with patient access, as well as information about the latest and greatest in clinical trials. So today my topic was monitoring, and there have been some very good questions in the chat, and I'll try to address some of them in the brief time allotted here. There was one question about penicillamine causing proteinuria, and should you ever go back after you've changed medication afterwards? Well, the question highlights first the fact that we do need to monitor the urine analysis in patients on chelation therapy, because there can be damage to the kidneys that causes a loss of protein into the urine, and other damage may ensue as well. So that when that does occur, that's a reason for changing medication and changing monitoring as well. And in these individuals, we typically don't go backwards. I'll show my age a little bit by knowing that when penicillamine was really the only medication available, patients were undergoing desensitization using steroids so that they might be able to tolerate the medication again. No reason to do that now with alternative therapies. There was another good question about what about during chelation therapy before and then after what happens to the non-ceruloplasmin copper and what happens to your 24-hour urine studies, and what should be the expectations. So a lot of that depends upon where the starting point for that individual is. If the disease is either fresh or uncontrolled, then the expectation is the non-ceruloplasmin copper is higher, and that with effective therapy, that should decrease with time. Now, interestingly, we always had expected that our goal for therapy for Wilson disease was to bring it back into what we call the normal range. And what is a normal range? So typically we have about 10% of our copper in our circulation that's not bound to ceruloplasmin, and that's bioavailable and used for our other metabolic needs. Now, surprisingly, in a recent study where we looked at, and this was the chelate study where trientine tetrahydrochloride was compared to penicillamine, we looked at the original registrants who came in on D-penicillamine who were stable with their disease. And interestingly, the amount of non-ceruloplasmin copper is actually below this 10%. So we really have to rethink and reestablish our targets for that. However, that said, the trend should be downward. And as pointed out by Dr. Roberts in her presentation from the French group, when things are not controlled, patients are non-adherent, that value drifts upwards. Now, 24-hour urine similarly can be helpful as well, although they tend to be a little more erratic and may fluctuate around the mean. That said, initially, prior to treatment, patients who have symptomatic disease tend to have elevated values, typically much greater than 100 micrograms. And if you start on chelation therapy, this can go as high as 1 to 2 milligrams a day, or even more in some individuals. And with time, this should decrease. And it varies a little bit in terms of the amount of copper put out, both by your dose based, and depends on medication as well. And certainly also the dietary copper intake during this time also can matter, but the trend should be downward for patients on chelation. Separately, there was a question in the chat about what about with zinc? If you start off with a value of copper in your urine that is typically under 100 micrograms a day, and then when you start on therapy, this may go down slightly, but your goal is to keep it where it is. For those who have values higher than that, the goal is over time to decrease it. And then after many years of therapy, whether it's on both zinc therapy or on chelation therapy, you want to follow that copper both in the urine, and then it's helpful also sometimes in the serum as well, just to make sure that you don't reach that point of overtreatment where the values may be extremely low. As we pointed out, you may want to measure a number of things, and it's not just the biochemical parameters, as Dr. Robert points out, it's how you feel that you should be well. And that's why we look at this in a holistic way. And for certain individuals with different manifestations of disease, we may need different specialty people, whether it's mental health experts or neurologists, to help make that better. And also to determine, how much is related to the Wilson disease, how much may be other factors as well. Now, there was a question about also monitoring and changing medications in pregnancy. So that's an option between the patient and their doctor, whether they stay on the same medication. But if you do stay on a medication such as trientine or penicillamine, the chelation therapies, dosage should be reduced as early as possible in the pregnancy so that you have less exposure to the fetus. But medication should be maintained throughout. For zinc therapy, you could maintain entirely during the pregnancy on that. Whether or not to change once you become pregnant, that's also a challenging question. There's no need to change if you dose reduce, as good outcomes have occurred on all the available therapies. So it's not an absolute necessity to change therapy. If you wish to do so, then you have to step up the monitoring to make sure that the treatment that you change to is effective. Same principle applies even in non-pregnant situations. Now, similarly, if you have other development of neurologic or psychiatric symptoms, after chelation over time, you have to then go into the concerns that Dr. Roberts raised. Do you have a treatment failure? In other words, are you no longer having effective therapy, whether that's related to the medication, how it's being used, other factors, dietary copper, or secondary injuries to the liver, or other ailments that are concurrent with the Wilson disease. And that's where you then require that very careful multidisciplinary group evaluation using the standard monitoring to try to see biochemically where you're at, as well as the clinical evaluations to see where in particular there may be challenges or secondary symptomatic therapy may be helpful. Now, there's a good question out there, and not necessarily related to monitoring per se, but is there recovery after a long persistence of symptoms in certain individuals? Well, there can be changes in therapy later on that might mobilize copper, but it really is dependent upon the degree of damage to the individual and to the structures. And if it's neurologic, then obviously we're talking about the brain. It's very hard to predict entirely. In one of the studies Dr. Ascari mentioned using the tetrathiomolybdate, we were really very interested to see that even long-term treated patients, when they were treated with that therapy, could have an increased mobilization of copper, and whether that could be done with current therapy that's available with stepping that up. That's always possible, but it's never certain that you will achieve change in the outcome, again, because that is very dependent upon the structures that were injured and whether or not there is reversibility. That is sometimes really challenging. There was a question about iron stores and being zero. If you have zero iron stores, you better look for other reasons for blood loss. Usually that's where endoscopic evaluation for whether it's other polyps or cancers or ulcers or things are probably very useful, or is there a very strict dietary limitation to copper in the diet? Usually we're actually in monitoring looking for, in potential overtreatment, looking for iron accumulation, not low iron stores. And that has to do with the fact that we need copper to help mobilize our iron stores. There was a separate question of what did I mean by posterior column symptoms. Again, that goes along with the long-term overtreatment. And in that case, we're talking about balance, and another thing, what we call proprioception. That's like the ability to sense where your limbs are. If you feel your toe, move it around, and you cannot feel that moving into a different position, that's a loss of proprioception in that. There was a question, how do we decide if a single dose regimen is appropriate? Understand right now that there is no FDA labeling for single dose use, and that is considered what we call off-label. That is something that can be discussed between you and your physician as to if that is a possibility. And then if you do it, and this is in particular for chelation, once a day zinc will not be effective for controlling the disease. However, you can use chelation therapy once a day if the dose is correct and if the patient is very stable going into that and monitored. But again, this is technically an off-label use, and you have to know it as such and has to step up the monitoring during that time to know whether that is particularly proper.
Okay, Dr. Santal, thank you very much. We do need to move on now.
Thank you, everyone.